Okay, so our next section is going to be on foot and ankle. We're going to start off with Cary Chapman, who's going to talk about the evolution of minimally invasive foot surgery, a paradigm shift, and then after him we'll have Justin Weatherall.
Hi, good morning. I'd like to thank Baptist International and Dr. Papp and Dr. Cardoso for inviting me here. I'm going to talk. Just keep on pressing. Okay. I'm going to talk about minimally invasive foot surgery. So, when making this talk, the first thing I had to figure out was, well, what is a paradigm? Paradigm is a set of accepted theories or methods and standards that define legitimate work within a scientific discipline like medicine or orthopedics. And in general, the scientist or the surgeon or the physician operate within these paradigms during periods of what's called normal science. And they solve questions that way and expand knowledge on that existing framework. Thomas Kuhn, who's a philosopher at Harvard, argued that scientific advancement doesn't really occur through the gradual accumulation of knowledge, but rather through a series of these revolutionary changes or paradigm shifts, as you've seen with total joints, revolutionary changes within what's considered dogma within a field. So what is minimally invasive foot surgery? It could mean a lot of different things to a lot of different people. Some people might think it's the same surgery, but you're doing through a small incision. But in general, it's performing a surgery through these smaller incisions or percutaneous incisions without direct visualization of what you're really working on. And typically that's performed with motorized burrs you see there in the middle under fluoroscopy. And behind that motorized burr, there's a power box that allows you to have high torque but low speed of the burr so you don't burn the bone. So the goals of MIS surgery are to have the same or better results as traditional open surgery: less risks, less pain, faster recovery, less scars. And in terms of what are we doing today in foot surgery, well, these are the basics: bunions, kylectomies, calcaneal, medial-lateral calcaneal slide osteotomies, hammer toes, or metatarsal osteotomies. And if you're talking about the history of MIS surgery in the foot, you have to go to the bunion. This first generation was started in sometime in the 80s, maybe the late 70s, and it was developed by a podiatrist in America named Stephen Isham. And he modified this osteotomy from France called a Reverdin, and they did not use any internal fixation. So this is all held together with literally strappings and tape. And this was the results were very difficult. He kind of brought this technique to Europe, and the Spanish and the Italians brought it to the next level, and this is the second generation technique where they use K-wire, temporary K-wire fixation, and they pulled the K-wires at some point during recovery. Once again, results very difficult to reproduce. There was AVN, pin track infections, and malunions. And finally, third generation, which was advanced in France and Europe, and they used the same percutaneous cutting of the bone, but combined it with AO technique with rigid internal fixation. So now we're on the fourth generation, late 2010s. Rather than doing a chevron, your typical chevron osteotomy for the first metatarsal, they use this transverse first metatarsal osteotomy. This osteotomy is an unstable osteotomy, but it does provide several advantages, mainly better screw fixation in the distal fragment, your ability to control the rotation of the head, and because you're not performing the chevron, on the picture at the bottom, when you put your screws across there, you reduce the risk of lateral blowout of the first metatarsal. So, why are we doing MIS surgery? Well, there is some cosmetic appeal to it. So the picture on the right is a typical open Lapidus procedure, and the picture on the left is a patient who had MIS surgery. So people say they don't care, but they care. It's also, respects biology. There's less soft tissue stripping, less disruption of the bones, of the blood supply, and it's hard to explain a patient on the top right, why their foot is purple and has this huge incision on it and a Band-Aid after 7 weeks. Luckily, that's not my patient. So there's also less wound complications. Like these are typical, as you know, the the skin on the foot is very thin. There's no soft tissue envelope. So when you have something like this, it's a problem. So there are studies showing there's faster recovery. There's studies showing there's less short-term pain. People use a lot less narcotics with this. They return to work faster. And there's actually a study that shows it improves your mental health. So if you, instead of going to the psychiatrist, you can come see your foot and ankle surgeon to take care of your problems. These are just a bunch of studies that came out in the last 5 to 10 years showing that this is a very viable technique. And this is one of the few long-term studies for any type of bunion surgery. And these are patients that had 5 years of follow-up. There was a vast improvement in the radiographic measures in terms of the intermetatarsal angle and the hallux valgus angle, and the recurrence rate. This is where I find it's made a huge difference in my practice. The recurrence rate is just less than traditional open surgery. I can't give you a good reason why, but I've definitely seen it in my practice. Additionally, patients have improved patient-reported outcome measures. And these are just a few studies, some of the few studies that are out there about traditional open surgery. And you can see, 10-year follow-up, patients have a 30% recurrence rate. And one of these studies show that there's up to 70% recurrence on bunions. So where are we going now with MIS surgery? So I can break it down to a few procedures. We're doing fusions, the forefoot, midfoot, and hindfoot. We're combining minimally invasive techniques with traditional open surgery. We're doing minimally invasive surgery, cutting bone for soft tissue problems. And we're also using it for our Charcot arthropathy reconstructive procedures. So this is just a patient who we're going to do a lapidus procedure on. So it's a different type of surgery, basically a fusion of the first MTP joint. And we've developed some jigs to help us with that. These are just some immediate post-op pictures, and here the patient is a year later and happy. This is a case of combining open surgery with minimally invasive surgery. This is a patient with lateral ankle instability, but she has a varus heel, so we all know that varus is the enemy in orthopedic surgery. We know that there is a high, when someone has a cable varus foot, there's a high incidence of recurrence after any type of foot surgery. So typically we would address that heel, either a Dwyer osteotomy or a lateral calcaneal osteotomy, a shift to laterally, and there would be your skin bridges, but you can avoid that now. Through a percutaneous incision, you can cut the heel. You can still do your open procedure for the lateral ligament reconstruction or your peroneal tendon tear. And rather than having these tenuous skin bridges on the left, you'll see that, I don't even know if you can see the incision there, but if I had a pointer, I'd point to the actual incision on the right where the osteotomy was done. So this is a situation where you can use MIS surgery to take care of a soft tissue problem, that being distal Achilles or insertional Achilles tendinosis and a Haglund's deformity. This is actually an old procedure developed in the late 1930s. And rather than debriding the tendon, taking it off the bone, cutting the bone, reattaching the tendon, and closing the skin, you can actually take a dorsal closing wedge osteotomy. So you take a piece of the dorsal part of the calcaneus, you close it down, you redirect the pull of the Achilles tendon, and it helps patients. So rather than risking something like this, these are uncommon, but it can happen. If it happens, it's a big deal. Also, the picture on the right is a patient who had a previous calcaneal surgery. The incision is essentially transverse, and it would go against your standard Achilles incision. It might cause a problem. So this is a patient, distal Achilles tendinosis. I make the apex of the osteotomy, which is plantar, and you see the osteotomy there. We'll use a percutaneous incision and a 3mm burr. And the little video on the left is we'll hyperdorsiflex the ankle, and that closes down the osteotomy. We'll put these through. once again, your incision, I can't point to it, but it's a very small incision on the lateral aspect of the heel, and we're not touching the patient's Achilles tendon. Some of these patients have a spur in the calcaneus, and I'm not touching that spur, and we're just leaving it as it is, and it makes them happy. And there's a recent study that came out with over 100 cases of this, and the patients have done well. Here's another scenario where I think MIS surgery has been very, very helpful. This is a patient with a midfoot Charcot. She has pain, rocker bottom foot deformity. We'll do our osteotomies through very small incisions, basically closing down the deformity, fixing the rocker bottom issue. These are the immediate post-op incisions. You can see the soft tissue prominence on the plantar aspect of the foot from her rocker bottom deformity. This is immediate, well, maybe 2 weeks follow-up. This is the patient at 6 months. So you can see the bottom of the foot is flat, no skin issues.
Can you go back, please?
Oh, sure. So in summary, minimally invasive foot surgery has, it's relatively new. It's like a lot of things in orthopedics. This is something that started years ago, kind of fell out of favor, and then the idea was recycled, but with a twist to make it more reproducible and more advantageous for the patient. So there's definitely less scarring. There's less pain, less opioid consumption. Less wound complications. You can use it with other open techniques. I do total ankles now, so obviously that's done open, but a lot of times these patients have bony deformities that rather than staging a procedure or doing 2 surgeries to fix one problem, you can now do your ankle first, and if there's a heel positional issue or first metatarsal needs to be osteomized, you can do these through percutaneous incisions and do it all at one time. And once again, I think we're past the fad stage, and this is the future. Thank you.
All right, so next up is Justin Weatherall, who's going to be talking about total ankle replacement, and he has a question. Have we finally figured it out?
All right, thanks for having me. It's a pleasure to be here. So I'm just going to talk about total ankle replacements. I did my residency from 2006 to 2011, and this was something that was not considered the gold standard by far. I remember my attendings telling me that gold standard was ankle fusion and that these had a really high failure rate. I did a rotation with Roy Sanders as a fourth-year resident. He did a lot of agilities, and he was dealing with a lot of the disasters of those agilities when I was there rotating with him. And it's just amazing that from there to today, I was just listening to a podcast on the way down here, listening to a couple of people on the AOFAS talk about how they almost never do ankle fusion now, and it's almost 100% ankle replacement. So just in the last 10 to 15 years, how things have really shifted. I don't have any pertinent disclosures related to this talk. So, where did we start? So we had the agility. It's what we consider the second generation. Kind of skipped over the first generation because they really weren't that successful. This is probably the first total ankle implant that really got a lot of wide use. It required an additional fusion there, so there was more than just putting the ankle in. You had to get the tibia and fibula stabilized. Really what the study shows, it could only handle some minimal deformity, and had a very high reoperation rate. So just at 8 years, almost 2/3 or over 2/3 of these patients had to have another surgery, and 40% of those were happening in the first year. So, definitely not an acceptable rate. I mean, some of these patients may not even been starting to weight bear till 6 or 8 weeks after, and here you are letting them walk on it for a few months and then telling them, we might need to go back in there. interestingly, Dr. Rakin, maybe he had a, got pretty slick with this or had good indications, but he even reported the highest I saw was 80% at 9 years. But I think for most people, they had very different outcomes with these. So the Salto Talaris, it's a third generation, three component, fixed bearing. It also had about a 25% reoperation rate at about 5 years. With an estimated survivorship of about 84% at 10 years. And if you had this kind of data with total hips and knees, they would find that completely unacceptable. And the issue with the ankle is when these things start to go bad, they go very bad. There's not a lot of bone stock there in the talus, so it makes reconstruction options very difficult. Additionally, we don't even have a revision component until just recently that could be relied upon. So when you look at some of these studies, they had below-knee amputation rates of several percent, which when you're talking to the patient in the clinic about, well, if things don't go right, there's not an insignificant chance you might wind up with an amputation, that really scares them tremendously. One of my mentors at Ortho Carolina, he used to have this line that he would say that would always raise a lot of eyebrows, but he would say, well, the good thing about foot and ankle is the worst complication we have winds up with a below-knee amputation, which, patients do pretty well with. Patients don't like to hear that. So then we moved on. We had the Integra, which was done in Europe, done a lot of cases there. And then in the U.S., kind of I think what really started to, change things was when the end bone came out. So we had the first generation of the end bone on the right. You can see that little jig that you had to put the leg in, very cumbersome. And that in and of itself added a lot of time to the surgery, depended 100% on external alignment guides to try to get everything corrected. So now we're on to the fourth generation of total ankle replacements, and this is where things have really moved along. This is kind of, since this fourth generation has come out, that's when what really swung the pendulum. And so Stryker, which is like the market leader for total ankles here in the U.S., I think they have about 71% of the market share. They have their kind of more minimally, bone-sparing implant on the left. They've done a modification to that original in-bone one where they made the talar component have a saddle, which added some stability to it with the implant itself. And then now they have a revision system to help us deal with some of the issues with these, such as bone loss. There's a few other companies that have come out on the market with ankle replacements. The Zimmer probably has the longest follow-up. The issue with the Zimmer is it's done through a lateral approach, so you have to cut the fibula, move the fibula out of the way, so that adds one more potential layer of complication of the procedure. That total ankle replacement might go great, but then they have a fibular osteotomy that may or may not heal. And then also it's all done through the side, so a little bit of question of how much balancing you can do in the coronal plane. And then the Vantage, recently there was a recall. That was the one I was showing before that from Exactech. They had a big recall because they had an issue with their the polyethylene component and how it was packaged. And then the Star implant, which has been around for a long time, also had some issues with loosening on the tibia. It was a three-component design where the actual polyethylene is not even attached to the tibia component and it's free to move. And that little extra degree of freedom, I think we've come to find out, may not be best for long-term survivorship. And then the Paragon ankle now is on the market. It has very limited follow-up, so I'm not going to spend much time discussing it. So just to kind of go back to the Star, because when I was in residency, this is kind of the one that a lot of my attendings were starting to do. It kind of, I think, initially piqued some of our excitement that we might have finally cracked the code with these. So the Star 2 was initially a two-component, then they added the third with the hydroxyapatite coating for non-cemented use. And Dr. Mann out in San Francisco, he showed a 73% survival rate at 15 years. The UK data showed 76% survival rate at 15.8 years, and that most of these failures were happening in the first year. And when some of this data started to come out, people were really initially excited about this implant. But some of the longer-term data has shown that the survivorship, probably isn't as acceptable as we would like. So as I talked about with the Zimmer, it requires that fibular osteotomy. It had about a 92% survivorship after about 2 years and about a 24% reoperation rate. and that was fibular hardware removal or medial gutter debridement, which makes sense because you don't really have access to the medial gutter, putting it in from the outside, and then you're adding in that extra complication of having to cut the fibula. And so with the Vantage, this one has only a couple years. It's only been on the market since 2016, so all the recent studies only have about 3-year follow-up. It's showing about a 6% implant failure rate, and then about 20% of the implants, just at about 3 years, are showing some lucency and subsidence, most commonly on the tibia component. Recently, I had a patient come into my clinic that had one of these put in a couple years ago, and the polyethylene had come dislodged from the tibia because the locking mechanism had failed. And so I'm going to go back to the Stryker. This, this is the one that I used. It's the one I trained on at Ortho Carolina. I think it's got the best long-term follow-up data, and for me, is very reproducible. So you can kind of see where it started from on the left. We had this big, bulky device we had to put their patients in, but now they've developed this prophecy system that's completely eliminated that. It shaved off about 30 minutes of the surgery because you send the patient for a CT scan ahead of time, tells you exactly what kind of size they're going to be in almost all cases, can address any kind of bone loss or bone voids or deformity. So it's taken a tremendous amount of the guesswork out of these. And they've even developed the lower profile implant. And then you have great fixation options in the tibia by being able to put in the stemmed component. And then also the revision option, which kind of piggybacks off of these other systems to make it even easier to swap certain components out and still keep other components in place. And essentially what it does is when you send them for the CT scan, they generate this report. They generate a 3D printed model of the ankle, and that 3D printed model mates with the cutting guide. So when you go in there in the surgery, you set that model right on the patient's tibia after you stripped off all the soft tissues, and it just keys right into place. It uses their bone spurs that they had before to fit exactly on there, so your cutting guide is going to match what's templated on the plan. So it takes away that external alignment guide and all the guessing that might have gone in there with the parallax of the fluoro and everything. So to me, that's been a really slick advancement that's happened in my career. And so this is the prophecy system. Just a picture on the left side tells you this is kind of what the plan looks like. It shows you exactly where the guide's going to sit. You can work with the engineers if there's subtle things that you want to change. That guide matches up to the bone, pins on there, and you can do all the cuts through that guide. You can even couple the tibia and tailor cuts at the same time with the ankle. So if they have really no deformity when you put their foot into neutral position, you can do all the bone cuts at once, which it dramatically shaves off the time of these surgeries. So the Stryker InBone 2 currently has our longest follow-up data. And I would say this data is very exciting. One of the reasons that there's been this massive paradigm shift from when we used to do all fusions to now we do almost all replacements. A gentleman on the podcast I was listening to this morning told me his age cutoff was 35 years and older, which to me, maybe that's a little young. I don't know if I'm going down that far for my age cutoff, but just in the last 10 years, it went from we don't do this at all to now we're even thinking about doing it on younger patients because we think this is going to last. So recent 2022 study, average follow-up of 5 years, they had 98% survivorship at 5 years, 8% reoperation rate, approximately 15% with peri-implant bone cysts. So much better data than what some of the other implants that are out on the market, and a lot longer follow-up. So they came out with the Infinity, which saves several millimeters of bone. I think one of the advantages to it is it retains a lot of talus bone, because when these things fail on the talus, that's when it's a major problem because you can lose a lot of bone stock in a hurry. So recent 2 to 5 year follow-up, almost 500 implants, 2-year survivorship of 99%. Non-revision reoperation rate of 3%. And then what some of the studies are showing is when these things fail, most of the failure is going to happen at 2 years. So I like to tell my patient, if we get to 2 years and you're doing well, the studies show that you're probably going to keep this implant. Most of the failures in the beginning are going to be infection or loosening. So the total knee survivorship, one of the studies I saw was approximately 99% of 5 years. I mean, that's incredible. And then 97% at 14 years. So our goal in total ankles is to get to that number. I don't know if we ever will because the soft tissue envelope in the ankle is a little bit different. The reason why people get this is a little bit different. About 70% of ankle replacements are because of trauma, not just wear and tear arthritis, but they've had something done to their ankle before, whether it's an accident or an ankle fracture, or they have just severe chronic ankle instability, so they do have, maybe their soft tissue envelope isn't great, but that's our goal. That's what we're working towards. I think it's exciting seeing what's going on with the robotic stuff in the total knee, because I do think in the future that's going to be very applicable to the ankle. Maybe we can do these through smaller incisions, try to decrease some of our wound complication rates. As I talked about before, most of these, based on the current total ankle systems with the in-bone, that most of these failures are occurring in the first 2 years. So I think we can give our patients a lot of confidence that once they make it past that mark, that they're probably going to keep this replacement long term. And then some recent data for the in-bone too that is going to be published is showing a 10-year survivorship of 93%, which is a huge improvement over the way things are in the past. One of my mentors used to, when he was a big adopter of total ankles very early, and he used to always tell us when we were fellows that an ankle fusion, it's a good operation, gets people out of pain, but an ankle replacement can be a great operation because it can get people out of pain and it can restore some motion, hopefully salvage, prevent them getting adjacent joint arthritis in the subtalar joint or the transverse tarsal joint that might have them back in your office in 10 years because they're dealing with symptomatic arthritis in those joints. And once you fuse the ankle and you start fusing some adjacent joints, it just gets stiffer, and that most patients, if you end up fusing the ankle and the subtalar and the transverse tarsal joint, so you get them the, tibiotalo-calcaneal arthrodesis, we used to call that the kiss of death, that the functional outcome of below knee amputation is better than someone that has a pan-talar fusion. So nowadays, I would say in the U.S., you go to the American Foot and Ankle Society, everybody's talking about ankle replacement. Now for us, ankle replacement is considered the gold standard. So very important contraindications because, when these go wrong, there's a chance you could wind up with an amputation. And so these are the ones you really got to be careful of, you really want to look out for. So uncontrolled diabetes, there's tons of stuff in the literature that this patient needs that their sugars need to be very tightly controlled perioperatively. And if they're just not a reliable person and they're just not taking good care of themselves, probably best to wait and hold off until they can get their health status in good shape, or maybe that's someone that just needs a brace. Blood flow, very important to pay attention to their blood flow because these wound complications are very hard to deal with. These patients get big wound breakdowns or eschards. You're looking at free flaps to try to salvage these, which can be a real big deal. Osteomyelitis, I always try to ask these patients if they're post-traumatic, were there any wound healing complications at all when you had your ankle fracture fixed or your pilon fracture fixed? Did you have to have any second surgeries? Did you ever go on antibiotics? Just to try to make sure that there's nothing hiding out in there that you're going to reawaken when you do this procedure. Obesity, if you compare the size of a total ankle replacement and the surface area of that to a total knee, there's just as much weight that this thing has to hold on to with a lot less surface area than what you might see with the total knee. So something to think about when you're doing total ankles on larger patients. And neuropathy, if you just read the technique guide, it says anybody that has neuropathy, it's a contraindication for this. I think really it's the patient that doesn't feel pain. They have, most of those are diabetic neuropathics, and that's definitely a contraindication. But if there are some people that have like Charcot-Marie tooth and stuff like that where they have these problems, I don't think that kind of neuropathy necessarily makes them contraindicated. I mean, a lot of them are in a lot of pain. That's why you're in the office. And if they can feel pain on their foot, I've had a lot of good success still replacing ankles in that patient population. And then Charcot, of course, contraindication because you could just waken that thing up and then the implant's going to fail. And now you got a big problem. So something to look out for there. And if they're, kind of going back to the uncontrolled diabetes, if they have uncontrolled diabetes and you do the ankle replacement, they can get Charcot in that ankle. So that's why I think very critical to keep their sugars under very tight control. And also just what are the patient's goals? I mean, if they're telling me they want to run marathons again or do these high impact activities, they may not be a good candidate for this. We really just don't know how much activity these implants can handle. And osteoporosis, definitely, I mean, almost everybody press fits these in nowadays, even though it's technically FDA approved for cemented use only. Everybody's press fitting from just because they get the bony in growth for longevity. And so if they have really soft bone, I think that's also a big contraindication. Thank you.
Okay, I think that was a great job. We're going to move to some questions. Any questions? Yeah, go ahead.
Good morning. Hello. Hello. Good morning. Very good talks for the ankle replacement talk. So, is there literature comparing the patient having previous trauma or IAF with patients having nothing, the results, the survival, the implant is the same, loosening, etc. And in these cases with this trauma, previous trauma with hardware, how do you really kind of approach the fact that they could have a lowering infection and that can impact the outcome in the future?
Yes. So as far as the trauma component, one thing you always look at is where are the prior incisions? Do they have any deformity from the trauma? Because that is always a challenge to deal with. If there's, the fibula was fixed in valgus or, and some of the literature. I don't know if we have enough even at some of these big centers where they've totally broken down and looking at it. I mean, there was a recent study out of Duke comparing difference in ages. So they looked at the younger patients that had total ankle replacements versus the older patients. And the older patients reported better satisfaction scores. They were happier after having it done. And there's that thought of, well, why is that? Was it because the younger patients were 100% trauma, total ankle replacements? Or is it just because the younger patients have higher expectations in that particular study? And maybe if you're 75 years old and you're not that active and your ankle's been killing you for 15 years, you're just happy to have something better than what you had before versus the 35-year-old that had a bad car accident and a bad pilon fracture 2 years ago. And 2 years ago, they were great. They were running around with their friends, and now they're limping all over the place. And they may still limp or may still have a little bit of pain and swelling after having an ankle replacement. Most of these are trauma. It's just that somewhat related. 70% of them are post-traumatic in general. So I think they can do very well, but I do think that does matter is their ages. And as far as the infection issue is concerned, if everything looks good, they didn't have any complications, post-op complications, they don't say anything in their history, then I don't worry about it. The other ones that maybe they're just a little swollen, they're a little red, I mean, they're going to get a workup from me, ESR, CRP, potentially even a bone scan, just anything that I can do. And then usually when you do the prophecy anyway, there's at least a month delay with that. So you got time to, or sometimes longer because you got to get a CAT scan first. You have time to kind of work a little bit of that stuff up. Cary does total ankles too, so he may have a little add.
Yeah, in general, I agree with all of that. I think that if a patient has a history of an open fracture, and I'll ask them if their bone was sticking out of their skin or anything, those patients I'm going to work up even if everything looks great, even if they didn't have any initial post-operative complications. So I'll do the ESR, and I depending what that shows, I might get a white cell labeled bone scan. Regarding the age or the trauma issue, I do think there's some literature out there showing that these patients have patients specific for trauma have lower functional outcomes and slightly higher revision rates, but that can also be a function of the fact that these patients tend to be younger. They develop their arthritis in their 40s and 50s, and they're getting their surgery at a younger age.
I don't know if it's because I have such a mundane practice or this is an interesting topic, but either way, thank you. It's very enlightening to us over here. Question, just curious about how the ankle works. We talk about joint reaction forces. The hip sees about 4 times with every step. The knee, especially in a nasty varus thrust, can see up to 6 times. Does the ankle follow those same thing, or is it it's still a very high joint reaction force environment?
Yeah, I think it's about 3 to 4 times through the talus. And in addition, I think one of the reasons why these things failed in the past, the quality of the bone, the subchondral bone in the distal tibia is different than in the knee. And also when you're thinking about the talus, I mean, you could cut it 2 centimeters off or take a little bit too much off, and then next thing you know, talus is dead. You know, it's just a different type of bone. So that's probably one of the reasons why these have had traditionally higher failure rates.
Yeah, I know me personally, I like the chamfered talus. That doesn't seem, you know, there's a lot of people in the foot and ankle world that still do the flat cut talus, but I just try to preserve as much of that bone as possible and give as much surface area of contact for the implant just to try to prevent problems on the talar side, because when it fails on the talar side and that thing just collapses into the bone, now you got a big bone defect to deal with, which can lead to 2-stage revisions and maybe even a year of time trying to get that patient reconstructed.
Thanks for the great talks, guys. I'm very unfamiliar with total ankle replacements. This is fascinating for us arthroplasty surgeons.
Yeah, we're trying to hide it from the total joint guys. We don't want you guys doing it. We worry it's getting too easy.
How do you counsel your patients on what things are going to look like post-operatively? You know, the total knees, we tell them you may have residual symptoms. The total hips, we tell them you're going to forget about it. Like, where does the total ankle kind of stack up on that spectrum of residual symptoms and how they're actually going to function?
So the 2 biggest things that I see is persistent swelling. And it's not in everybody. I have a lot of ankle replacements. I look at their ankle and they're just like thrilled. It doesn't swell anymore. It looks great. They're happy. And then I have those that are seeing me a year out and it still swells and they still have a little bit of pain. The ankle replacement that I use, it doesn't resurface the gutters, so I try to do a good job getting on each side of the ankle to try to get some of that stuff out. But you know, maybe I miss one in the back or something like that, or there's just a little impingement there in the fibular gutter, the medial mal, that I think does cause pain, especially when they're walking and the ankle's being fully dorsiflexed. You know, but if they're having 7 to 10 out of 10 pain, and I get them to a 1 to 2 out of 10 pain, usually pretty happy with that.
Yeah, I tell patients between a total ankle and a fusion. I mean, I think the studies have shown that the pain relief is equivalent. It's just that total ankles tend to have this issue of needing some type of maintenance procedure. So granted, we've gotten the failure rate or the revision rate down, but there's still more patients than I'd like to see have some other type of issue, like gutter impingement. You're developing osteophytes, and that causes pain. And you still have to go in and do something for that. Whereas a total ankle, an ankle fusion, once it's healed, I mean, you really don't have to worry too much afterwards. Granted, some patients will develop subtalar arthritis or talonavicular arthritis, but most patients don't need that next surgery. They don't need a pantalar fusion. They just kind of live with what they have.
I think one thing's nice is the MIS system. The couple that I had to take back for gutter debridement, since that's come out, I do all those MIS. So it's just a little poke hole, so it's really minimal downtime for the patient.
You're not afraid of that burr messing up the ankle?
No.
Poly?
It's usually distal in the gutter, you know, down near the bottom, away from that stuff.
Yeah, in the cases that you need to do a revision of a primary arthroplasty, do you think about going back like to a fusion or versus using revision implants?
Well, I think bone stock is important, and then just a conversation with the patient. I mean, some of them, they really want to keep their ankle motion. So the revision is a little, for them, that's more appealing to them. Because the fusion is a TTC, so if they have, if their subtalar joint's still working pretty well, it's going to be a much stiffer ankle than what they had before. I trained with a bunch of guys that did a lot of total ankle replacement, so maybe I'm a little biased to that. We weren't doing a lot of big TTCs. We were trying to revise these and fix these in fellowship, so I've been trying to do the same thing with my patients.
May I? So we get a lot of complicated cases that get referred from abroad, and question I have for you is, on these complicated cases, for us to be able to refer towards you, what are you looking for as far as in imaging? What's the best thing? How could the physicians abroad help you best to set up a patient for it to be seen for a second opinion or something like that?
Standing x-rays, you know, that's always key for us. Standing x-rays and just their history like infection or, you know, diabetes, those types of things. You know.
Yeah, I think a clear history would be good, because it's hard for a layperson to understand, you know, whatever issue they had before. Why did things fail? I don't think we need to worry about CT scans, because we probably want to do them here, because there's a specialized CT if we're going to do some type of reconstructive procedure. And even the x-rays, you know, if it's a non-standing x-ray, it's really not very helpful. So a lot of the stuff, honestly, just get the patients over. We'll take care of the workup.
More mundane question. With regards to the bunion surgery, I saw you did osteotomies of the proximal phalanx for bunion correction, for hallux valgus. But those halices looked normal. So what is your threshold for doing your...
You mean adding like an achinosteotomy to the...
Yes.
Yeah, I would say that for a standard minimally invasive bunion, where we're cutting the first metatarsal neck and the proximal phalanx, 99.9% of the time, I'm going to I'm going to do the achinosteotomy, because people like their toes straight. I mean, there's sometimes these things creep back just a little bit, so we never really cut them into varus or anything like that. It's cut, and the toe is straight. You know, sometimes the thing will creep back into valgus, and if you've, I don't want to say overcorrected, but if you've made that correction, you don't have to worry about it. But I would say that 99.9% of the time I'm doing aching.
Yeah, same for me.
So I'll ask a quick question. I saw what looked like a mid-foot fusion nail with your MIS talk. That didn't exist. Is that something that's off-label use, or is it helpful? Like
Well, it is specific for like a medial column fusion, so it's not for the ankle. It is a specific nitinol product, so it actually has some internal compression once you get the thing in there. But it's so in the old days, we'd do this huge whack along the medial column and put a huge plate on there or two, and a million screws.
That's my generation.
Well, that's my generation. That's my generation too.
It's still going on, I would say.
Yeah, it's still going on. But you know, obviously, you have intramedullary fixation is better than using plates, and now you see that you don't have to make that huge whack to do your osteotomy to realign the foot. So it's not that new, but it's relatively new.
I think it's great. Were there any other toys that you use that are different than was used, whatever, 15 years ago?
I'm sorry, say that
Are there
again?
different, like, implants such as, like, that?
I don't know. What do you think?
I mean, I would say I finished my fellowship in 2012, and it's remarkable how many of my surgeries are done differently today than it was in my fellowship. I mean, bunions, we did a lot of opening wedge, course distal chevron, some lapidus, zero MIS, and now everything's shifting towards MIS. We couldn't fix no one knew how to deal with metatarsus adductus in a bunion, and now I think we're coming up with some solutions that are all MIS, which are super exciting, because I really used to just tell those patients, you know, keep your IMA angle is normal. I know you got a terrible bunion, your toes are windswept. I don't know if I got a surgery other than a hallux MTP fusion to fix you. Now with MIS, that's to me really exciting. The only thing I feel like I've seen with MIS, maybe it's just me, but they do tend to swell a lot, you know, because sometimes some of these bone cuts are not internally fixed with screws. Maybe you're strapping the toes or holding them down, and it takes longer for those bones to unite, because they're not compressed together like AO technique. They're floating a little bit, so you're depending on secondary bone healing. You know, so that's been the only little thing that I've seen is patients will swell a little bit longer than I used to do an open distal chevron.
Yeah, I agree. I finished my fellowship in 2004, and I don't do anything like I did back then.
No, thank you very much. I think this concludes our foot and ankle session. We're going to move on to a break. So go get some coffee, and yeah, we'll see you later.